Hi, my name is Jason Kim. I'm a urologist at Stony Brook and I specialize in FPRMS and neurourology. Today I'll be talking about neurogenic lower urinary tract dysfunction. This can be a very complex topic and I find that I often have to re-review the information myself. I'll try to highlight some of the areas that may be important for your in-service tests or board exams as we go through the lecture. We will discuss the review of the neural control of micturition and the neurology involved. We'll discuss the evaluation of neurogenic lower urinary tract dysfunction, and then we'll discuss specific examples of neurologic conditions that may cause neurogenic bladder. And we'll also devote part of the lecture to autonomic dysreflexia, which is often tested on your in-service exams. I'd like to start by apologizing and saying this presentation is going to be very text heavy. I typically like to insert a lot of figures and illustrations in my presentations. However, the subject matter just doesn't lend itself to that. So as an intro, there are two main functions of the lower urinary tract: storage and periodic elimination of urine. So basically, we spend most of our lives in the storage phase, and a very short phase in the elimination phase of urine. So basically, our brain has to tell us when it's a socially acceptable time to urinate, and we have to be able to hold it until that time. We don't want to be wetting ourselves when it's not appropriate. And the two functional units in the lower urinary tract include the reservoir, which is the urinary bladder, and the outlet, which consists of bladder neck, urethra, and urethral sphincter. And to maintain these two functions, there has to be coordination between these organs, and this is mediated by a complex neural control system located in the brain, spinal cord, and peripheral nerves. Oftentimes, when we consider the micturition reflex, I think most of us consider the efferent innervations. This is what actually makes the bladder contract, the sphincter relax or contract. This diagram shows the efferent innervations to the bladder and sphincter mechanism. We'll be talking in detail over the next few slides about the efferent innervations. There's a complex interplay between the pelvic nerve, which is a parasympathetic input to the bladder, the hypogastric nerve, which is the sympathetic inputs to the bladder and sphincter mechanism, and the pudendal nerve, which is a somatic nerve and innervates the external urethral sphincter. First, we'll start by discussing the parasympathetic efferent innervation to the bladder. So the parasympathetic innervation provides a motor innervation to the bladder. This is what actually allows for bladder contraction when stimulated. The parasympathetics originate in the intermedial lateral gray matter of the sacral spinal cord in the S2 to S4 region and run through the pelvic nerve. This does travel through the pelvic plexus. The pre- and postganglionic nerves release acetylcholine. This is an excitatory neurotransmitter and an acts on muscarinic receptors within the detrusor muscle. It usually acts on the M2 and M3 receptors. There are 5 subtypes of muscarinic receptors. It's thought that detrusor contraction is primarily mediated by M3 receptors. The sympathetic innervation of the bladder arises from the thoracic and lumbar T11 to L2 spinal segments. And during bladder filling, noradrenergic nerves provide inhibitory input to the detrusor and excitatory input to the urethra and bladder base. So basically, when the sympathetics are active, it allows the bladder to relax and allows the urethra and sphincter to tighten. And this leads to bladder relaxation and urethral contraction. The sympathetics do run through a complex route. It starts at the sympathetic chain ganglia, running through the inferior mesenteric ganglia to the hypogastric nerve and the pelvic ganglia. So the sympathetics are really mediated through the hypogastric nerve. And the sympathetic nerves are not essential for micturition. When the sympathetics are active, it does allow for bladder relaxation, urethral contraction, allows bladder to accommodate larger volumes at lower pressures during filling and storage. However, it has been shown that surgical injury and pharmacologic blockade lead to reduced outflow resistance, decreased bladder capacity, and increases in frequency and amplitude of non-voiding contractions. The somatic innervation to the external urethral sphincter and pelvic floor originate in the ventral horn of the spinal cord in an area called onus nucleus in the S2 to S4 segment. It travels through the pudendal nerve to innervate the striatum muscles of the external urinary sphincter and pelvic floor. The neurotransmitter involved is acetylcholine, which acts on nicotinic receptors. Recall that parasympathetics also release acetylcholine, however, they act on muscarinic receptors, so this is a little different. Um, Once the nicotinic receptors are activated, it leads to muscle contraction, which would be tightening of the pelvic floor muscles, and also the external urethral sphincter, which promotes urinary storage. During urodynamics, we might see increase of activity of the sphincteric EMG with bladder filling. And this leads to bladder outlet resistance, which is mediated through the firing, increased activity of the pudendal nerve. Next, we'll shift gears to the afferent innervation of the lower urinary tract. Once again, we're dealing with the autonomic and somatic nervous systems, and we all are dealing with the pudendal nerve for somatics, the pelvic nerve for parasympathetics, and the hypogastric nerve for sympathetics. However, most of the signals actually most of the afferent signaling goes through the pelvic nerve or parasympathetics. And what we see is at lower filling volumes of the bladder, once the receptors are activated in the parasympathetic system, we get a gardening reflex, which are local projections of interneurons on a local level from the pelvic nerve, and that leads to increased sympathetic output, which, as we had discussed before, leads to bladder relaxation and accommodation, and also leads to increased firing of the pudendal nerve, which tightens external urethral sphincter. However, as the bladder continues to fill and the stretch receptors note that the bladder is full, the signals now project to second-order neurons within the spinal cord and travel up to the supraspinal levels for further processing. As I just mentioned, the pelvic nerve, the hypogastric nerve, and pudendal nerve all carry afferent information from the lower urinary tract to the lumbosacral spinal cord. The pelvic nerve provides the majority of the afferent information from the bladder, and there's a smaller component from the hypogastric nerve. Signals from the striatum muscles of the sphincter and pelvic floor travel through the pudendal nerve. So the cell bodies of these nerves are found in the dorsal root ganglia of the S2 to S4 and T11 to L2 dorsal roots. Their axons enter the dorsal horn, where they may project locally to interneurons, and this promotes a guarding reflex, which I talked about, which is increase of sympathetic activity leading to bladder relaxation, and increase of sphincter contraction, and which promotes storage of urine, and this is mediated through the hypogastric and pudendal nerves. Or these axons may project to second-order neurons, which ascend to supraspinal centers involved with control of micturition. And these interneurons make excitatory and inhibitory connections, and it facilitates segmental spinal reflexes or sends longer projections to the supraspinal centers. The afferent nerves consist of small myelinated A delta fibers and unmyelinated C fibers. The A delta fibers are found in the detrusor muscle, and they respond to detrusor stretching during bladder filling, which conveys a sense of fullness. The C fibers are found in the detrusor muscle and lamina propria. They respond to noxious stimuli, provide nociception, and are sensitive to changes in temperature and pH. They're mechanosensitive, so they gradually increase discharge frequency as the bladder fills. And there's successive recruitment of mechanoreceptors with different thresholds during bladder filling. And these thresholds for recruitment correlate with intravesical pressures at which humans express first sensation, first desire, and so forth. The supraspinal centers involved in afferent signaling include the periaqueductal gray matter and the punctum micturition center. The punctum micturition center is actually kind of like the master control switch. It's either in storage mode or in kind of micturition mode. During storage mode, the signals that it sends leads to increased sympathetic and somatic output, which mediates storage and quiets the parasympathetics, while when it's in voiding mode, it's the exact opposite. So the supraspinal centers, they're responsible for integrating afferent commands and descending signals from higher brain centers to transition from storage to voiding. And so what this means is the afferent signals I think they come up to the periaqueductal gray matter, kind of conveying a sense of fullness. And then other portions of the brain, I think the frontal cortex and other portions, we're not entirely clear on this process. Tell us whether it's a socially acceptable time to void. If it is, the signal gets sent from the periaqueductal gray matter to the punctate micturition center, and then the punctate micturition center moves into the voiding mode and decreases sympathetic and somatic output, increases parasympathetic output, which leads to voiding. So in cats, it's been shown that the stimulation of the punctate micturition center led to reflex voiding. So experiments that interrupt the connections from the periaqueductal gray to the punctate micturition center in cats led to reflexive voiding in the cats. However, in rats, it was shown that the periaqueductal gray plays a critical role in reflex micturition. So the whole process of how the brain integrates the signals really is not clear at this point. So as you can see, a healthy lower urinary tract requires neural coordination with the spinal cord and brain. And just to review, the afferent pathways convey sensory information on bladder fullness, and the efferent motor pathways respond, resulting in voluntary urinary control. And dysfunction of the afferent node pathways alters the balance of inhibitory and excitatory stimuli critical to voluntary bladder control. And there's been a lot of debate where conditions such as overactive bladder, is it an afferent or efferent issue? And it seems that most people these days believe it may be an afferent signaling issue that leads to abnormal signals and conveying a sense of urgency and frequency. This is just an illustration that I took from the Neurogenic bladder core curriculum, which I think is based on the guidelines from the American Urological Association. So you guys should all have access to this. So basically what we see here is if we start at the bladder level, we see the afferent nerves, which travel mostly through the pelvic nerves, and it travels up the sacral spinal cord, up the spinal thalamic tract to the periaqueductal gray matter. And based on input from the kind of frontal lobes of the brain, then it either tells the punctate micturition center to remain in storage mode or to allow voiding. And if it allows voiding, basically signals are sent back down the spinal cord, and as I mentioned, the sympathetic output increases. The sympathetic output decreases along with the somatic output, and the parasympathetic output increases, allowing for bladder contraction. This schematic shows the different nerve activity during storage and voiding, and I think it serves as a good review, kind of a basic review. However, I do think this diagram will be helpful for some in-service questions. I do recall seeing in-service questions like during voiding, what happens to parasympathetic, sympathetic, and somatic motor activity. So basically what we see on the top left is the urinary bladder fills, stretching the bladder wall, and afferent impulses from these stretch receptors, they either go to the brain or it's a simple spinal reflex. An example of simple spinal reflex is actually infants. Their higher order brain centers aren't fully developed yet. So when the stretch receptors say the bladder's full, infants undergo kind of like a simple spinal reflex, which leads to reflex voiding with increased parasympathetic activity, decreased sympathetic, and decreased somatic motor activity. However, as the brain and spinal cord mature, the afferent impulses from the stretch receptors are actually going up to the brain to the higher order centers, such as the periaqueductal gray and eventually punctate micturition center, and the decision is made whether to be in storage mode or in a micturition mode. And this kind of diagram shows you what happens to nerve activity in each state. So I think it's a nice review. Okay, after that review of the physiology of voiding, which can be kind of complicated, we're going to shift gears a little bit to pathophysiology and evaluation. So really, it's important to understand the neurologic disease that you're dealing with, because when you want to predict the neurologic impact on bladder function, you really need to understand the location of the neurologic pathway, whether it's in the brain, the spinal cord, the peripheral nerves, because a lot of times knowing that information is enough and you can kind of predict what kind of voiding dysfunction one may have. This table was taken from the core curriculum for the subject from the AUA. However, I thought it was nice because it shows you some of the possible causes of a neurogenic bladder. So as I mentioned, we have to divide it up by a location of neurologic insult. So there's suprapontine, infrapontine to suprasacral causes, and infrasacral causes. I'm not going to read them all off, but some of the things that can cause suprapontine causes of neurogenic bladder include things as stroke, Parkinson's disease. We know that, for example, in a stroke, that the most common voiding dysfunction is overactive bladder, neurogenic overactive bladder. It's not uncommon that I get a patient with a stroke in my office and they said, wow, my urgency incontinence has significantly worsened. I'm urinating every 20 minutes. And no one's actually told them that it may be related to the stroke they had. Same with Parkinson's disease. We know that one of the most common voiding issues with Parkinson's disease is urinary urgency and frequency and urgency incontinence, and it makes sense because this is a suprapontine cause. In the infrapontine to suprasacral regions, basically spinal cord regions, things like spinal cord injury, multiple sclerosis, they can cause a lot of problems. And it's really important to characterize the level of lesion because you can have such entities such as detrusor sphincter dyssynergia or autonomic dysreflexia, and these are things that are potentially high risk to the patient. Infrasacral causes can include diabetes or Codd-Aquinas syndrome. So evaluation for neurologic lower urinary tract dysfunction really is dependent on the type of extent of neurologic disease with predominant consideration of potential risk to the upper tracts. Basically, what it means is we want to prevent damage to the upper urinary tract and preserve renal function. Some of these conditions may cause decreased compliance or urinary retention or abnormal pressures in the bladder that may be transmitted up to the kidneys and may eventually cause a kidney failure. And initially, we classified the risk level as either low risk or unknown. And if it's an unknown risk, you'll need further evaluation to allow for complete risk stratification. This is the basic algorithm from the AUA guidelines for neurogenic bladder. So, we'll talk a little more in detail about this, but you initially evaluate the patient with a history of neurologic disease. You want to get a history and physical, get a post-void residual to see if they're retaining urine. And some optional tests include voiding diary, pad tests, uroflow. But we don't routinely perform cystoscopy at this point. So, low-risk conditions, including things like stroke, Parkinson's disease, brain tumor, basically suprapontine causes, and lesions distal to the spinal cord. And it's considered low risk if the patient is spontaneously voiding, they have a low PVR, and their renal function is not compromised. If we perform urodynamics, we might see synergistic voiding, and if there's upper tract imaging, there's no significant abnormalities. And basically, their symptoms are stable. Everyone else is considered an unknown risk, and further evaluation is needed. Things that present with unknown risk are suprasacral spinal cord lesions, such as multiple sclerosis or spinal cord injury, and other neurologic lesions with identified genitourinary complications, such as bladder stones, elbow PVRs, recurrent UTIs, or changes in the symptoms. And we'll go through some more of this stuff in the upcoming slides. So if we look at the risk stratification, there's a few key things we can look at: renal function, post-void residual, urinary tract imaging, and urodynamics. Now, not all patients may have urinary tract imaging or urodynamics. For renal function, low risks would be normal, moderate risk is normal or stable, and high risk might be abnormal or unstable. Low risk has a low PVR, moderate risk may have an elevated PVR. Urinary tract imaging is not necessary for low risk, but if you have it, it shows that there's no significant abnormalities, and same with moderate risk. High risk patients may show hydronephrosis, renal scarring, loss of renal parenchyma, or staghorn or large stone burdens. And urodynamics will show synergistic voiding in low risk patients. Moderate risk may have neurogenic retention or detrusor overactivity and complete emptying. High risk may have poor compliance, reflux, or high storage pressures with either detrusor overactivity or detrusor sphincter dyssynergia. As mentioned previously, an unknown risk includes suprasacral spinal cord injury, MS, transverse myelitis, spinal dysraphism, or any neurologic lesions with identified worsening lower urinary tract symptoms such as hydronephrosis, bladder stones, ureteral dilation, elevated PVR, or recurrent UTIs. And we need to further evaluate or reevaluate these patients, especially if their symptoms have changed, to determine if they're moderate or high risk. So the initial evaluation for neurologic disease includes a history and physical and UA when they're able to void, and we should always obtain a post-void residual. Optional studies include voiding diary, pad testing, and non-invasive uroflow. Cystoscopy is not routinely recommended. Urodynamics may be performed when there is a change or worsening in signs and symptoms or new complications, or upper tract renal function deterioration in patients with moderate or high risk neurogenic lower urinary tract dysfunction. Evaluation for risk stratification should be performed once acute neurological event resulting in the condition is stabilized. And I think the classic example would be spinal cord injury. We know that for a period after injury, the patients develop something called spinal shock, which is a flaccid paralysis with absent bladder and bowel function, which eventually may transition into hyperreflexia and the typical voiding patterns we've seen in patients with spinal cord injury, including detrusor overactivity or possibly detrusor sphincter dyssynergia. However, the time frame from spinal shock to this transition can be variable. It could be anywhere from maybe a month, and the report said even it may last a year. So we have to kind of use our judgment at the best point to get to evaluate for risk stratification after these kind of injuries. So during the initial evaluation for neurogenic disease, low-risk individuals should not routinely undergo upper tract imaging, renal function assessment, or urodynamics. So, as I mentioned, these are mostly suprapontine causes such as stroke, neoplasm, things like that. However, for unknown risk disease, clinicians should obtain upper tract imaging, renal function assessment, and urodynamics. Cystoscopy is not recommended for standard screening or surveillance for patients with neurogenic issues that are managed with or without chronic indwelling catheters. However, cystoscopy should be performed for concomitant things such as hematuria, recurrent UTIs, or suspected anatomic anomalies such as false passages or strictures. I pulled a fast one on you guys and changed my scrubs when you weren't looking. Anyway, when we talk about surveillance for neurogenic disease, if we look at low-risk disease and for patients with stable urinary signs and symptoms, as we mentioned before, and no significant post-void residual and no other significant symptoms, and you really don't need upper tract imaging or urodynamics. However, if things do change, if the patients start experiencing worsening symptoms or conditions such as autonomic dysreflexia, the patient should be reevaluated. New risk stratifications should be performed. And the clinician should also instruct, or the clinicians are instructed to educate patients to look for these red flags and avoid waiting until the next appointment. So if the patients start having worsening kidney function or difficulty emptying or elevated post-void residuals, things like this, we can consider, or we should do a reevaluation to see if the patients have moved into a moderate or high-risk category. Surveillance for high-risk neurogenic disease includes an annual focus history and physical exam, annual renal function assessment, annual upper tract imaging, and annual multi-channel urodynamic studies with or without fluoroscopy. However, for moderate risk neurogenic disease, you want to do the history, the physical exam, symptom assessment, annual renal function assessment, and upper tract imaging every 1 to 2 years. Urodynamics is not necessary. So if we look at neuroanatomy classifications, let's first look at cortical lesions or suprapontine lesions. And these are things that are essentially in the brain. Examples include stroke, Alzheimer's disease, Parkinson's disease, things like that. And cortical lesions typically do not cause compliance issues, detrusor sphincter dyssynergia, or upper tract damage. These patients typically exhibit neurogenic detrusor overactivity with synergistic voiding. These are considered low-risk patients, and evaluation may consist of urinalysis and post-void residual. You want to rule out additional causes for bladder dysfunction, and although not necessarily complex cases, may benefit from cystoscopy and urodynamics. So here we have an example of the urodynamics from a patient with a neurogenic bladder who suffered a stroke. So in an 87-year-old female with urgency incontinence, frequency, and nocturia that started 2 months after a left frontal lobe stroke. I just wanted to show an animation of what urodynamics may show. So what do we see here? Well, first of all, we determined that this urodynamic tracing, the portion we see here, is during the filling phase. We see that it is a decent test because the pressure in the abdomen at the cough is transmitted to the vesical pressure, but not to the detrusor pressure. And then we see as we fill, we see that the patient exhibits detrusor overactivity in the yellow line, the rise there, and we can see a concomitant increase in EMG activity. And also we can see associated in purple a flow, which probably indicates urgency incontinence. This is classic for neurogenic detrusor overactivity. We do see increased EMG activity, not because of detrusor sphincter dyssynergia. This is during the filling phase, so this is probably more like a guarding reflex. They're getting a bladder spasm and they're consciously kind of squeezing down on their sphincter muscle, which is reflected in the EMG. So in this condition, a stroke, what we see is loss of frontal cortex inhibition of the punctine micturition center, which leads to neurogenic detrusor overactivity. So as you recall, we say the punctine micturition center is kind of the main control that determines whether you're in a storage phase or avoiding phase. And signals from the afferent signals from the bladder travel up the spinal cord and usually reach the periaqueductal gray matter, and then inputs from the frontal cortex areas determine whether it's socially acceptable time to void, but that portion gets disrupted. And so basically the punctine micturition center just activates, and that's why you see detrusor overactivity. So in the case of a stroke, we see that the location of the lesion is above the pons or cortex. The bladder is overactive, the sphincter acts appropriately, and the coordination is synergic. And treatment of these patients is similar to non-neurogenic overactive bladder. First-line therapy, maybe behavioral therapy, second-line therapy, pharmacotherapy, and third-line therapy, procedural interventions. So we can consider similar to overactive bladder. Next, let's look at lesions of the spinal cord. This is kind of where we can get into moderate and high risk. So this is where we have to actually do more of an evaluation. And it's categorized according to the American Spinal Functional classification. 80% of spinal cord injuries are male, and most common causes are motor vehicle accidents, falls, violence, and sports injury. Supraspinal cord lesions include spinal cord injury, tumors, infarcts, transverse myelitis, and possibly multiple sclerosis. And this is the region where you're at risk for abnormal compliance to the bladder and detrusor sphincter dyssynergia. And these are things that are worrisome, as they could impact renal function, which is really what we worry about. Urodynamic evaluation is frequently mandated. Many of these patients are considered high risk and may need yearly urodynamics. Also, upper tract monitoring for hydronephrosis and stone disease is additionally indicated. And as I mentioned, the focus is on upper tract protection to maintain renal function, and lifetime follow-up is indicated. So now we have a representative urodynamic tracing for a patient with a supraspinal cord lesion. So we have a 52-year-old female with urgency incontinence, frequency and nocturia, and a history of multiple sclerosis. So let's look at the urodynamics. When I look at the urodynamics, the first thing I want to do is to see if it's a adequate test. I look in the beginning, I see there's a cough and the pressure is transmitted to the vesicle tracing, but not to the detrusor. So we know that this is a good test. Next thing I'd like to do is look at the where the filling phase starts and ends and where the voiding phase is. Because similar tracings in the filling phase and voiding phase, they can have different implications. So if we look at this, we look in the filling phase and we do see that there's some detrusor overactivity during the filling phase. But what's more worrisome is during the after the permission to void is given, we see there's an appropriate rise in detrusor pressure, but we see there's increased sphincter activity and a poor urinary flow. So this points to detrusor sphincter dyssynergia, and where there's lack of coordination between the sphincter and the there's lack of coordination between the sphincter and the detrusor muscle, resulting in a poor urinary flow and although it's not noted here, probably an elevated post-void residual. This is where there's potential risk for upper tract deterioration in the long term. So it's something that we have to monitor for life. So when we look at supraspinal cord lesions, as I mentioned, there's loss of coordination between the sphincter and the bladder muscles. As you recall, normally the sphincter relaxes and then the detrusor muscle squeezes. That doesn't happen in detrusor sphincter dyssynergia. And so if we look at the location of the lesion, I'm adding to the table from the lesions above the pons and cortex. Now, if we look at suprasacral, we see that the bladder may be overactive, as we saw during the filling phase. We see that the sphincter could be spastic, and there's dyssynergia. So in these patients, it's essential to screen for reflux and hydronephrosis. So oftentimes in multiple sclerosis patients, when I'm doing urodynamics, I'll get video urodynamics. That way I can look for reflux during the test, and we might get a kidney ultrasound to assess for hydronephrosis. What is the treatment of these patients? So typically we would recommend clean intermittent catheterization to minimize bladder volumes, and then we can consider anticholinergics, beta-3 agonists for pharmacotherapy to relax the bladder for spasms, or consider Botox injections. If the patient is unable to tolerate CIC, in conditions such as multiple sclerosis, oftentimes they lose manual dexterity and can't perform intermittent catheterization or don't have a caregiver who's willing to do this, then we may have to consider a urinary diversion, such as appendicovesicostomy, ileovesicostomy, or ileal loop. We like to avoid indwelling catheters. Honestly, I see quite a few patients, spinal cord injury or MS patients who've had indwelling catheters, especially in females. It can be devastating as long-term. They develop urethral erosions. I mean, this can happen both in males and females, but in females with a very short urethra, we see a lot more. What happens is they might start with a 16-French catheter, and then people start complaining there's leakage around the catheter, and they might go to 18, 20, 22, 24, and then there's still leakage around the catheter. By the time they get to me, I'll remove the catheter, and honestly, I can put maybe 2 or 3 fingers in the urethra into the bladder because it's so eroded. I mean, then that becomes kind of a little bit of a management nightmare. So we like to avoid the indwelling catheters. If you need a catheter, I would strongly recommend placing a suprapubic tube catheter. The other thing that we have to look out for in supraspinal cord lesions is autonomic dysreflexia. I'm going to devote a few slides at the end of the lecture to this, as this topic is often tested on the in-service exam. Autonomic dysreflexia may present with excessively high blood pressure, bradycardia, and sweating and flushing. And this happens if the lesion is at or above the 6th thoracic vertebral level, T6. Next, we'll talk about sacral and peripheral lesions. They include lesions below the sacral cord or injury from pelvic surgery. Most often result in normal compliance and detrusor atony, often combined with a fixed external sphincter. So we quite often might see urinary tension from these patients from an acontractile detrusor muscle. Impaired compliance may be present. Urodynamic evaluation is frequently mandated. Upper tract monitoring is also additionally indicated, and many patients require intermittent catheterization. And again, these patients will need long-term urologic follow-up. Here we have an example of our urodynamics. Again, I look for the filling phase and voiding phase. This is a 62-year-old female with incontinence, frequency, and nocturia that started after colorectal surgery. So what we see here is that the patient, when they try to urinate, we actually see in the detrusor, which is the yellow line, that they really make almost no detrusor pressure during voiding. So this is probably a acontractile detrusor muscle due to nerve injury. And again, we see that there's a very poor urinary flow, and this patient is likely not voiding to completion. So if we look at sacral cord and peripheral lesions, the bladder usually is acontractile and the sphincter is flaccid. Okay, we're going to shift gears now and talk about autonomic dysreflexia. Autonomic dysreflexia is seen in 60% of cervical spinal cord injury patients, about 20% of thoracic spinal cord injury patients. And common triggers are stimulation of the urethra, prostate, internal sphincter region, or distension of the bladder or rectum. Some of the symptoms of autonomic dysreflexia include hypertension, diaphoresis, and bradycardia. And this results from unregulated sympathetic nervous system stimulation and output below the level of the lesion. And this occurs primarily in patients with spinal cord injury above T6. And this can be triggered by noxious stimuli below the level of injury, things such as urinary retention, urinary tract infection, detrusor overactivity in the setting of impaired compliance, constipation, fecal impaction, and sacral decubitus ulcers. So what are some of the signs, symptoms, and signs of autonomic dysreflexia? Well, first we see hypertension. Some patients we do see reflex bradycardia in about 10% of the cases. However, tachycardia or no significant change in heart rate is more commonly noted in most patients with autonomic dysreflexia. They'll often have a pounding headache, and they will have flushing and sweating above the level of injury, especially the face and neck with cold limbs. You'll see pilar erection, which are goosebumps and shivering above or below the lesion. They may develop blurry vision with or without the appearance of spots in the visual field, nasal congestion, anxiety, dyspnea, malaise, and nausea. And these are all kind of sympathetic type symptoms. So what is the prevention and treatment of autonomic dysreflexia? Well, number one, clinicians must hemodynamically monitor patients with neurogenic dysfunction that are at risk for autonomic dysreflexia. As I mentioned, spinal cord injury above the level of T6 during urodynamic testing and or cystoscopic procedures. And clinicians must terminate the study, immediately drain the bladder, and continue hemodynamic monitoring. And for patients with ongoing autonomic dysreflexia following bladder drainage, clinicians should initiate pharmacologic management and or escalate care. One example I can remember in my practice is I had an 18-year-old paraplegic who was in a motorcycle accident. He had a lesion in the spinal cord above the T6 level, and we had been managing him with a suprapubic tube. However, every time he came in for a suprapubic tube change, he developed autonomic dysreflexia. With blood pressures that would go into the 250s, and he would develop bradycardia and some of the other sympathetic symptoms. And it got to the point where we actually had to, every time we changed the tube, bring him to the emergency room for hemodynamic monitoring, and we'd actually put nitro paste on his chest prior to changing the tube. So what is the treatment for autonomic dysreflexia? Well, oftentimes this may occur when we're doing things such as cystoscopy where the bladder is getting distended. The number one thing you should do is just stop and drain the bladder and remove the noxious stimuli. You also want to remove tight clothing and straps, monitor heart rate and blood pressure every 5 minutes, assess for constipation and fecal impaction. And if the patient doesn't improve with these kind of conservative measures, then for continued hypertension, you have to consider giving either nitroglycerin sublingual, or you can consider captopril 25 milligrams sublingual. And patients should be monitored after the autonomic dysreflexia event and educated about recurrent symptoms. I think I'm going to stop here. Most of the information here was taken from the 2021 AUA SUFU guidelines for adult neurogenic lower urinary tract dysfunction. I encourage you to review these guidelines, and I think most importantly to understand this table which I showed before, which evaluates for risks in these patients. We could go on and keep talking about specific conditions such as stroke, MS, and the different presenting signs and symptoms. However, I think this actually gives you the basics to kind of figure out the most predominant patterns. So always kind of try to locate the level of the lesion, and once you locate the level of lesion, you can usually understand what the most predominant avoiding dysfunction would be. I will say that, especially like in spinal cord injuries, the level of lesion doesn't always correlate with what it should be, so you have to understand that also. So I think I'll wrap it up there. I'd like to thank everyone for listening to this lecture. I hope it was helpful. I hope everyone has a basic understanding of the neurology involved in the normal voiding reflex and how to determine how neurologic injury can impact voiding. If anyone has any questions, please feel free to reach out to me at my email address, which I've listed below. Thank you and best of luck.